Hi, this is the first in our series of strabismus lectures this year. It's going to be going over anatomy and motor physiology. Welcome to our new first years. I hope you enjoy this. Your job is going to be to review this session, review the chapter in the book, and then send me any questions you have for clarification. So the goal of this session is to have you build a knowledge base of extraocular anatomy and physiology to use as a basis for understanding strabismus as we move forward through this lecture series. Specific objectives for this session include you should be able to describe the anatomic relationships of the extraocular muscles, including the positions of the origins and insertions, and of course the cyclovertical muscles. Secondly, you should be able to list the primary, secondary, and tertiary actions of each extraocular muscle. And lastly, you should be able to apply Herring's and Sherrington's laws, which are two of the laws of motor physiology, to common forms of strabismus. To begin discussing the anatomy of the extraocular muscles, we'll consider the innervation. This slide shows the posterior orbit with the globe removed. As you can see, the extraocular muscles are demonstrated with their innervation. The fourth cranial nerve, the trochlear nerve, enters the orbit through the superior orbital fissure. Outside the annulus is in and innervates the superior oblique muscle. The sixth cranial nerve enters the orbit within the annulus and innervates the lateral rectus muscle. And there's two branches of the third cranial nerve. The superior branch innervates the superior rectus and levator, and the inferior branch innervates the medial rectus, the inferior rectus, and inferior oblique. As we go through, we'll have a number of assessments during the quiz and review them at the end. So read over this, come up with your conclusion. You'll see the answers in the next few slides. So this deals with the distance of the muscle's insertion from the limbus, and which muscle's insertion is usually nearest the limbus. The medial rectus, the lateral rectus, the superior rectus, the inferior rectus to the superior oblique. Feel free to pause, come up with your answer, and review over in the next couple of slides. So this is a schematic describing the spiral of Tillot in a right globe. As you can see, the medial rectus is the closest to the limbus, about 5.5 millimeters. The inferior rectus about 6.5, lateral rectus at 6.9, superior rectus at 7.7 millimeters. This is important when you're assessing reoperations and where the muscle might be located. And you should realize that you don't have to hook very far back when you're doing strabismus surgery to find the muscle insertions. The next few slides are going to describe how the cyclovertical muscles have secondary and tertiary actions. The muscles do not line up perfectly with the optical axis of the eye, the pupillary axis. Instead, the muscle plane is offset to some degree from the optical axis, which gives the muscle its secondary and tertiary actions. This slide is demonstrating that the vertical recti cross over the optical axis at an angle of about 23 degrees. So when the eye is in slight abduction or slightly turned out, the vertical muscles act as pure elevators or depressors because the optical axis will be in line with the muscle plane. If the eye is able to adduct completely to 67 degrees, then those muscles act as pure tortors. They rotate the globe about the anterior-posterior axis. The oblique muscles are demonstrated in this schematic. These have a much larger angle to the optical axis, and this is why these muscles act primarily as tortors of the globe, or rotators around the anterior-posterior axis. Some books have this angle at 51 degrees, some at 57 degrees, but you can see that in primary position, if the inferior oblique muscle pulls, it's going to create a large amount of extortors in the eye. If the globe were able to rotate into adduction 51 degrees in the bottom left picture here, the inferior oblique would act as a primary elevator, or pure elevator, whereas if it's abducted slightly 39 degrees, it's going to act as a pure tortor. And you can review this at your leisure. Next anatomical relationship I want you to understand is the relationship between the oblique muscles and the vertical rectus muscles. So both the superior oblique and the inferior oblique run anatomically inferior to the rectus muscles. So this means that the superior oblique muscle runs between the superior rectus muscle above and the globe below. In this picture, the levator and superior rectus have been reflected anteriorly. You can see the superior oblique running below the superior rectus. In the right frame of this schematic, you can see that the inferior oblique also runs inferior to the inferior rectus. So again, this is going to run between the inferior rectus and the floor of the orbit, not between the inferior rectus and the globe. And these relationships are important when you're isolating these muscles during surgery. A final bit of surgical anatomy that's important, especially in patients who have thyroid disease, is the relationship between the lower lid retractors in the inferior rectus and inferior oblique. There's a structure called Lockwood's ligament which attaches the inferior rectus to the lower lid retractors. When you're doing surgery, especially recessions of the inferior rectus in patients with thyroid disease, you'll often get a lot of lower lid retraction. If you're able to free up this band of white tissue that's on the surface of the inferior rectus before you do a recession, you'll have less lower lid retraction and more patient comfort afterwards. The next test question has to do with the vascular supply to the anterior segment and a surgical complication called anterior segment ischemia. So anterior segment ischemia is most likely to occur in which of the following situations? A 9-month-old undergoing bilateral medial rectus recessions for congenital esotropia. B, a 24-year-old undergoing right lateral rectus recession and right medial rectus resection for sensory exotropia. C, a 67-year-old diabetic undergoing right superior rectus and right inferior rectus transposition to the right lateral rectus, as well as a right medial rectus recession for 6th nerve palsy. Or D, a 77-year-old undergoing right inferior rectus recession for thyroid eye disease. So take your time, answer this question, and move on. So the arterial supply to the anterior segment, including the cornea, the iris, and the lens, is supplied by the anterior ciliary arteries. And these arise, usually 2 of them in each rectus muscle, except for the lateral rectus, which usually has 1. This can be variable. Sometimes you'll see 3 on the surface of the muscle, sometimes 1 on the surface of the medial rectus. The other important anatomical relationship of the vascular supply is the vortex veins border the superior rectus and inferior rectus, usually about 10 to 12 millimeters post the insertion. These can be ruptured at the time of surgery and can bleed a lot, so it's important not to patch hook too far posteriorly in order not to injure these vessels. Okay, we've covered anatomy. We're going to move on to physiology at this point. So each of the extraocular muscles has a primary action, and the cyclovertical muscles, which are the superior rectus, the inferior rectus, the superior oblique, and the inferior oblique, have secondary and tertiary actions to rotate the globe around 3 axes. Globe. Then rotation around the z-axis, or the superior inferior axis, is going to cause abduction or adduction of each eye. Here's a fun little assessment. Which of the following is incorrect? A, the medial rectus adducts the eye. B, the inferior rectus extorts the eye. C, the inferior oblique intorts the eye. D, the superior rectus adducts the eye. Or E, the superior oblique depresses the eye. So take a minute, pause, come up with an answer, and come back. Okay, so here's a table that goes over all the primary, secondary, tertiary actions of the extraocular muscles. It's a lot to take in. When we get to the lecture hall, we're going to kind of use our hands to act as the globe and our fingers act as pulleys to show how these muscles work in the orbit. The simple mnemonic that I have in my head to remember these is SIN and RAD. So SI for SIN means the superior is intort, and RA or RAD is the recti adduct. So if you know these two, you can know the converses, which means the inferior is extort and the obliques abduct the eye. So with the simple SIN RAD, you know all the actions of all the muscles. Okay, we've kind of conceptualized movements of the eyes. We're going to get into some of the details about how we name these. So ductions are monocular movements. So you can cover up the left eye, the right eye can elevate, depress, abduct, or adduct. Versions are conjugate binocular movements. So it's going to be both eyes together. And it's going to be moving in the same direction, either left gaze, right gaze, up gaze, down gaze. And vergences are disjugate, which is a word that I never really knew existed until coming up with this lecture. Disjugate binocular movements. So this is going to be convergence where both eyes move in towards the nose, or divergence where they move out towards the ears. Terminology here for eye movements. Agonists are 2 muscles in the same eye that have the same action. You can kind of think of these a couple different ways. So right superior rectus and right inferior oblique are both elevators of the eye, so they're agonists for elevation. The left inferior rectus and left inferior oblique are both agonists for extorsion. You can come up with a couple other pairs here. Antagonists are 2 muscles in the same eye that have opposing actions. So right medial rectus and right lateral rectus are antagonists because the right lateral rectus abducts, the right medial rectus adducts. So again, agonists and antagonists are 2 muscles in the same eye. The physiological concept that comes along with antagonist and agonist is Sherrington's law. It concerns reciprocal innervation. So it states that an increase in innervation and contraction of one muscle is accompanied by reciprocal decrease in innervation and contraction of its antagonist. So when I'm looking to the right, my right lateral rectus gets an increase in innervation, increase in contraction, And the right medial rectus is going to have a concomitant decrease in innervation and contraction to let my eye rotate out to the right. An interesting way to think about Sherrington's law is to think about the things that violate Sherrington's law. So Duane's co-contraction syndrome violates Sherrington's law. In this situation, the medial rectus and lateral rectus fire at the same time, both causing contraction and increased innervation, and causing retraction of the globe. Okay, moving on from agonist and antagonist, here's a question about yoke muscles. So which of the following are yoke muscles? The right medial rectus and the right lateral rectus, the right superior rectus and left inferior oblique, the right superior rectus and left superior rectus, the left inferior rectus and left inferior oblique. Okay, so when we're discussing one eye, we'd have agonist and antagonist as two muscles working on one eye. We talk about binocular movements. Yoke muscles are two muscles in the opposite eyes. They move the eyes into one of the cardinal positions. So the right medial rectus and the left lateral rectus are yoke muscles for left gaze. The right superior rectus and left inferior oblique are yoke muscles for up and to the right. Left inferior rectus and right superior oblique are yoke muscles for down and to the left. This is a quick schematic outlining the yoke muscles for the cardinal positions. And here's the same concept but with schematic eyes to show you which muscles are working. Okay, when we're discussing inductions, we had Sherrington's law. When we're discussing binocular movements or versions, Harrington's law applies, and it talks about motor correspondence of the yoke muscles. So it says that equal and simultaneous innervation goes to the muscles that move the eyes into a certain position. And this explains secondary deviations, which you can talk more about in lecture hall, as well as the pseudoparesis of the contralateral superior rectus and fourth nerve palsies. And we'll have a schematic about this in a second to talk through. Okay, this is a very involved schematic and probably take a few times for you to work your way through this. So there's two sections, the top section and the bottom section. This patient has a right fourth nerve palsy with the superior oblique being weak. And the important parts to look at are gaze up and to the left. So let's take the bottom schematic initially because it'll make a little more sense. With gaze up and to the left, the left superior rectus and the right inferior oblique are both the primary elevators in that position of gaze. And if you think of the left superior rectus being the fixing eye, it's giving 100% of elevation in this eye. The right inferior oblique is also getting 100% of innervation to go up that high. And the antagonist right superior oblique is not working very well, so you get a mild over elevation of the right inferior oblique to get a right hypertrophy in up and left gaze. Okay, let's look at the top panel now. In this panel, the right eye, the predicate eye, is fixing. So when it tries to look up into the left, the right inferior oblique does not have to use very much energy because there's no antagonist right superior oblique to hold it down. So to get up to the same position, it might only require 50% of innervation to get up into the left. The same 50% of innervation is going to the left superior rectus, so that eye is not elevating very much at all. So this is the pseudoparesis of the contralateral superior rectus and fourth nerve palsies. So work through it a couple more times. Just understand that the relative innervation, the right inferior oblique and left superior rectus is going to be the same, looking up and to the left. With the predicate eye fixing, don't need very much innervation to get that eye up. So DVD is an unusual eye movement, and it's unusual in part because it violates Herring's law. So in this picture, the top left picture has a child with straight eyes. He also has spontaneous left hypertrophy or dissociative vertical deviation here. When that eye comes back down to take up fixation, you do not have a concomitant depression of the right eye. So this is violating Herring's law because the right eye is not introducting when the left eye comes down. With a few high-yield facts in the post-test, you can just read over these as you wish. Okay, here's the post-test. Get your answer in your head. Pause. I'm going to tell you the answer in just a second. Okay, so the medial rectus is the one that is closest to the limbus, usually 5.5 millimeters back. We'll talk, but it came through during the introduction. Pause here and we'll come back with the right answer. The Correct, incorrect answers C, E parentheses T should be intermediate stropion, not dystropia near.